mitigation COVID-19. This is our 7th CBD program, and there are about 120 doctors participating with us today. And this is a 1-hour workshop, which is done by Dr. Mahen Kotalawale, consultant clinical microbiologist at National Hospital, Kandy. Please be kind enough to mute your microphones and your video cameras during the workshop. And if you have any questions, you can direct them to the lecturer panel by using a chat box. Now I warmly welcome Dr. Mahen Kotalawale to start this workshop. Over to you, sir.
Thank you very much, ladies and gentlemen, for giving me this opportunity. And today, what I thought was to discuss some aspects on COVID. So basically, I'll be talking about COVID risk mitigations for professionals. So basically, the whole idea is to have some idea about what we are going to do to prevent spread of COVID-19 among healthcare workers. So basically focusing on that aspect. So before my presentation, I would like to introduce the 2 words that I am going to use throughout my presentation. That is risk and mitigation. So what is a risk? So if you take the word risk, it says avadanama or avadanam. Then what is the term mitigation means? Awama kirim, right? So in my this 1-hour talk, basically focusing on those 2 words. So how do we involve in reducing risk of transmission of COVID first among healthcare workers and then to the community. So in my presentation, I'll be using this frame to present to you whatever the facts that I have to produce to you. So first, I'll be talking about 2 examples of nosocomial spread of COVID in Sri Lanka. Then I'll be giving you the concept of risk scale of acquiring COVID-19, moving to transmission dynamics, and then viral transmission, and the factors which govern the transmission of COVID within the community and institutions. And then I'm talking about prevention of COVID-19 in healthcare setting. And then I'll be introducing the concept of exposure risk assessment, and I'll be talking about how we are going to use the risk assessment framework, exposure risk assessment framework in assessing the risk of healthcare workers. And then I'll be discussing some true clinical scenarios with you. So first of all, I would like to give you this bold statement. COVID-19 is not easily transferable. So I'm taking 2 examples from the hospital that I work, National Hospital, Kandy. First one is the ENT Clinic Incidence. So in a typical day, the ENT clinic provides services for around 125 to 150 patients. So there are around 40 healthcare work personnel attached to ENT Clinic of National Hospital, Kandy. So here you can see from this graph, the basic arrangement of the ENT clinic. You can see the patients were seen in the corridors and they were asked to come in one by one to be seen by doctors. And there's a registration desk, there's audiologist room and the speech therapist room. And on either side, there are rest rooms and dinner or tea rooms. So basically, this is the organization of ENT clinic within our hospital. What I'm going to discuss the outbreak which taken place within these premises. So on 25th November 2020, 2 healthcare workers diagnosed with COVID-19. So when there is evidence of nosocomial or hospital spread, we generally further investigate into this. So on the following day, we have identified 15 additional healthcare workers who are having COVID-19. So, and this is the scenario on 24th November. You can see the red individuals, the healthcare personnel, were the carriers or the disease spreading individuals. On 24th of November, within the practice of ENT clinic, there had been 17 contagious or infectious individuals within the practice, the hospital unit. As a result of that, there had been 9 nurses, 4 healthcare assistants, 2 audiologists, and 1 speech therapy and 1 doctor who's from another ward got the disease. Altogether, there had been 17 patients, 17 healthcare workers infected with COVID-19 during that 2 days time period. But the cardinal feature of this outbreak is no doctors or patients got the disease. Here you can see the doctors seeing patients. There are nurses, the healthcare workers, the healthcare assistants were roaming around the theater, potentially spreading the disease, spreading the viruses all over. But instead of that, none of the doctors or the patients got the disease. So some doctors have been working on that area for more than 4 hours for 2 days, consecutive 2 days within the time period. But all 4 doctors who have visited that place during those 2 days were disease-free upon testing. So we have sent them compulsory home quarantine, but after quarantine period, we got to know that none of them were infected. So if the disease is easily transmissible, like we are thinking right now, all 40 personnel within the healthcare institute, the ENT clinic, should have got the disease. And also, in addition, there has to be some patients who was getting the disease. But fortunately for that, only 17 healthcare individuals who were infected originally were the affected parties at that place. So then the second incidence is eye operation theater incidence. 6 healthcare workers attached to eye operation theater were diagnosed with COVID-19 on 21st December 2021. So that is after the famous Brandix and Paliagoda fish market cluster. 1 detected on the first day and 2 other nurses and 5 others were detected later. So now in this scenario, 2 infected nurses who were contagious, they were having symptoms, and in spite of having symptoms, they were assisting the surgeon and anesthetist to carry out the surgery and to continue the surgical list. Here you can see with this infographic, you can see 2 nurses, 1 assisting and the other runner were having COVID positive, and they were actively helping the surgeon to carry out the surgical list. But no healthcare worker, the surgeon, anesthetist, or no patient were affected from COVID because of the fact that they were basically wearing surgical masks. So in these 2 instances, many healthcare workers and patients were safe, but they were not got the disease because of the fact that COVID is not easily transmissible. Why? Simply because COVID-19 is not transmissible as easily as we think. So you can see when you go to hospitals, many healthcare workers wearing this so-called PPE, the wraparounds and the coveralls. But they don't understand the fact that it is not transmissible through skin, and it has to be, the droplets should come in contact with the upper respiratory tract epithelium to get the disease. So they are not concerning on covering nose and mouth, but they are thinking all covering them up with the coverall and wraparound gowns. Simply, these people who didn't got the disease were following the very basic steps of infection prevention. As a result, they didn't get the disease. All of them were practicing minimal risk minimizing behavior. So risk minimizing behaviors is the famous wear mask, wash hands, and stay at safe distance. So if you practice these things, especially wearing mask 24/7, you can get rid out of the problem very easily. All other healthcare workers and the nurses and other healthcare assistants or the doctors, they were wearing surgical masks. As a result, they didn't get the disease. And after that, I'll be moving to the concept of risk scale. Risk scale means the chances of getting infection with COVID-19. It is given as a picturesque presentation. Yeah, in risk scale consists of 0 to 100 scale. So if you were to get out of the disease and not to have risk of developing infection for 100%, you have to stay at home. So the lower risk end is staying home. The other risk end is the getting the disease. So anything, so your activities, day-to-day interactions may have a scale from 0 to 100 depending on the risk that you are going to take when you are engaging in that interaction, that social interaction. So the best way to get out of the outbreak, to get out of the disease, stay safe from the disease, is stay home all the time. But we know in practice, it is very difficult to stay home all times because of the commitments that we are having or that we are having to prevent the spread of disease. So once you move out from home, once you increase the interactions, the chances of infection will be increasing. So this photograph shows you the low risk behaviors, medium risk behaviors, and high risk behaviors of the interactions, the social interactions that you have. If you can't stay at home, the best thing to come out of the problem is to inculcate practicing or having a behavior engaging only on low risk behaviors. In that way, you can stay safe. The concept of new normal originated to define how well a person adapts to continue his day-to-day work without risking the person himself or the others to COVID-19. So basically the new normal concept is to stay safe and while continuing your work. So therefore, it is very important to identify the disease and the pathogen in order to reduce transmission. The new normal involves the changing of our lifestyle to acquire minimal risk behaviors. As I shown you earlier, it is very difficult to stay home to get out of the problem. You need to interact with the society. And if so, what you have to do is you have to acquire minimal risk behaviors to your lifestyle so that with the minimal risk behaviors, the risk of transferring or risk of getting COVID-19 will be minimized. So here you can see the changing lifestyle in order to prevent transmission. To acquire the minimal risk behavior, we need to know how this disease is transmitted between individuals. So the thing is called transmission dynamics of SARS-CoV-2. So if we know the transmission dynamics, if we know the features of virus which promote transmission, you can avoid them. And to acquire safe behaviors or low risk behaviors by everybody will delay the transmission of SARS-CoV-2. So I'm moving to transmission dynamics of, when you are discussing about transmission dynamics, you should know the ways of transmission of disease and the source and the mode of transmission. So COVID-19 is spread from person to person. It is not a zoonotic disease. It is not any other type of disease. It is a disease which transmits from person to person. An infected, contagious person forms the source of infection. So the source of infection is the human, which can be transmitting the disease to somebody else. So if you minimize interactions between individuals, between the members of society, the risk of meeting a contagious person will be less, so that you will be minimizing the risk. And the predominant mode of transmission is droplet transmission. So if you know these things, the source, the mode of transmission, you can avoid the risk of getting the infection. You can reduce the risk of getting this. So other mode of transmissions, the contact transmission and aerosol transmission. So we will discuss about droplet transmission. When an infected person breathes, talks, sings, coughs or sneezes, droplets containing virus will emitted to outside environment. Once these droplets passes through nasal passages of a susceptible person, it will initiate the pathologic process on the epithelium of nasal mucosa. So once the virus attached to the receptors of the nasal mucosa, there is no way of reversing it. Either you use the smoke or any other steam or any other substance on or gargle or use anything, you can't reverse that. If one exposes to high viral load means high amount of viruses, the probability of infection will be high. So therefore, exposure of high viral load means exposure of more virus carrying droplets. If one remain closer to a contagious person, the risk of acquiring COVID-19 is high. Here you can see a contagious person producing droplets. You can see the highest amount of droplets are concentrated in closer to his portal of exit. So that is the nose and mouth. So as it goes further into away from the patient, the contagious person, the concentration of droplets will drastically drop. Higher the time you spend with a contagious person, the risk will be high. The probability of infection will be proportional to type of respiratory activity. So if the contagious person is breathing at rest, the number of droplets produced, contagious droplet produced by the infectious individual will be less. If you speak, it will be more than that. If you sing, it will be further increase. If you exercise, the droplet concentration will be more. Shout, concentration will further. Cough, it will go further, it increase further, and sneezing. So the type of respiratory activity decide the amount of droplets that a contagious person produce. So in that case, if you can avoid face-to-face confrontation with a symptomatic individual, the risk of acquiring COVID will also go down. Understanding the virus transmitting. So when we talk about the virus transmission, there are two important concepts that we have to understand. One is contact emission rate. It is given as ERQ. So contact emission rate means, and the second one is airborne infection risk score, AIRS. So these two concepts, if you can understand and if you can work out a plan to minimize these, you can get out of the problem of getting COVID. So first we'll see what contact emission rate is. Contact emission rate means, quanta means as in quantum physics or quantum theory, it is the number, the packets, the number of packets. So the amount of packets of infected particles emitted by a contagious person. So it is number of infectious particles emitted by a contagious person per hour time period. So if the number of contact is increased or high, the chances of infection will be increased. So this contact emission rate is expressed in quantum emission rate per hour. So generally, it believes that a contagious asymptomatic or post-symptomatic person emits around 50 infectious droplets per minute. So here he can see an instance where high quanta emission is there. So a symptomatic patient producing droplets containing viruses comes into face-to-face with a susceptible individual and in close proximity. You can see the number of quantum of infected particles will be high in this instance. The same instance, if the contagious person wearing a mask, the number of quanta produced within the time period will drop significantly. So when you have low quanta emission, the risk of infection is less. A symptomatic patient emits more quanta of droplets containing viruses than an asymptomatic patient or a post-symptomatic individual. So the second concept is airborne risk score, airborne infection risk score. So this risk score reflects the probability of acquiring COVID-19 after an exposure. So here I have demonstrated this. One contagious person sitting in front of a person who is susceptible. So this infectious person produces number of contagious particles amount X, and the susceptible person inhales a contagious particle number Y. So if the contagious person produces more infected particles, the chances of the second person getting the disease will be high. And again, if the second person, the susceptible person, inhales more quantum of droplets, the chances of infection will be high. The third parameter which comes into this equation is the degree of dispersion or destruction of viral particles from within the environment. So if the dispersion is more, and if there is more destruction of the viral particles, when it emits into the environment, the risk of infection will go down. So generally, when you multiply these X and Y, you get the risk of transmission of the disease. The reciprocal of dispersion will be the other factor which decide airborne infection risk. So when the dispersion is more, the risk is less. When the destruction is more, the risk of getting COVID is less. When one produces more quanta, the risk is increased. And when produces less when less is inhaled, by effectively wearing mask, you can reduce X and Y, and by distancing between the contagious person and the susceptible person, you can increase the dispersion and destruction of the viral particles. So in this way, you can minimize the risk. If you know quanta emission and the airborne infection risk score, we can actively take steps to reduce transmission. So when you are calculating airborne infection risk score, there are 5 parameters that you have to consider. One is room dimension. So generally, within a room, if you have a surface area of 50 square feet per person, so that signifies less sort of overcrowding. So generally, if you are working in a closed environment, you have to have at least 50 square feet of area to stay safe. If that square area is less, the chances of infection will be high. Then the second parameter which we consider when we are calculating airborne infection risk score is the infectious viral removal rate. So if you allow the air to come in, the rate will be high. If you erect any barriers, the infectious viral removal rate will be reduced. Then the initial quanta concentration, so that is the difference of quanta produced and the quanta inhaled. And then total time of occupancy. When the total time increases, the risk of getting infection will be high, and the exposure scenario. So these 5 parameters are very important when we are calculating the airborne risk score. The airborne infection risk score predict the probability of transmission of virus from source to a susceptible host. Where high airborne infection risk score will increase the transmission of the disease, and low risk score reduces the disease. So as professionals, what we try to do is we have to make measures. We have to take measures to reduce airborne contact production and also reduce the airborne infection risk score. So if we know how to do that, we can stay safe, and also we can tell others how we can stay safe during this COVID outbreak. The tools such as airborne infection risk score and contamination rate per hour will guide us to understand how to stay safe during the outbreak. Contamination rates in different settings. Here you can see a closed space, a person producing different types of droplets, the contact, number of contact. When the person is breathing, you can see from 3 planes, 3 graphs or 3 photographs, the number of contact produced with time. Here, if he's breathing, the number is less. If he's speech, the number is, and if they are singing or shouting, the number of droplets produced within a time will be increased. So if you are within an enclosure, it is always better to stay without speaking or without shouting or without singing. All these things can be done outside. The contact transmission. Contact transmission is not considered a significant mode of transmission of COVID than droplet transmission. The airborne transmission is another way of transmitting COVID, but it is basically limited to closed environments. The airborne transmission is important in closed buildings when more infected person present at any given moment. And if they stay longer within the building, the transmission risk will be high. So the risk posed by airborne transmission are reduced in outside. Still, from the knowledge that we have about the transmission dynamics of the outbreak, we can say droplet transmission is the major mode of transmission. A recently concluded study reveals that the contribution from droplet transmission is 90%. The fomite transmission and airborne transmission is 10% to all these things. So if we have means of prevention of droplet transmission, we can reduce the spread of outbreak. So the other concept that I'm going to talk is infective dose. The infective dose is the number of virions required to initiate the infection process. For COVID-19, it is believed we need around 1,000 virions to establish or initiate the disease. If you inhale subnormal levels of virus, so that is virus less than 1,000, the disease won't progress. So there has to be a threshold level of 1,000 viral particles. Infective dose always need to be expressed in relation to number of complete virus particles. It is not related to RNA levels in the sample. It's always the number of live viral particles. It is not based on RNA concentration. There are 1,000 particles could be delivered. This 1,000 threshold level can be delivered from a single exposure. So you can get a single exposure. Or this 1,000 can be delivered 10 exposures, which has 100 particles each. Or it can be delivered 20 exposures of 50 virions each. So that means you can get the disease from a single exposure or gradual exposures over time. If you come into face-to-face with a person who is sneezing or coughing with symptoms symptoms, the infective dose can be delivered in a single step. So if you come to face with a cough of a person who is contagious, 100% you are sure that you will be getting the disease.